So welcome back. Today we'll be talking about ankylosing spondylitis, and it was first described by the Greek and Roman physician Galen from Pergamon. And he practiced around 162 AD, so about 500 years after our friend Hippocrates. And he was very interested in the layout of the human body on the inside. And at a time in human history, at least in this place of the ancient world, in this spot, human dissection was not allowed. So he would have to mainly study other animals, such as apes. But he was also in charge of the gladiators in the Colosseum. So whenever the gladiators cut them each other open, he and his team would run out, they'd take a quick pick on the inside, and then as a surgeon, he would sew them back up. And actually, he was a very good surgeon. And he goes on to become the physician of the emperors in Rome, and he does research of the spine. And he is the first to describe ankylosing spondylitis. Now, ankylosing spondylitis is when the immune system is overactive the wrong way, and it starts to attack the spine in a very specific manner. So if you can imagine taking a rope ladder that's very flexible and can twist and turn, and now suddenly all those ropes are calcified. So that's what happens in ankylosing spondylitis. The ropes that are connecting the bones to the bones, they get more calcium put into them, and as a result, the bone becomes more immovable or fused. So the symptoms of ankylosing spondylitis is significant morning stiffness. This is where patients will wake up, they will have stiffness for hours and hours in the morning that is better with activity. They also get inflammatory low back pain. So again, this is pain in the lower back that only gets relieved when the patient kind of gets up and moves around and then tries to go back to sleep. These patients can get fusion of the spine in different parts, meaning that some of them will just get attacking of the ropes that connect the bones in the lower part of the spine. Sometimes they can go upwards to the middle of the spine, and then sometimes it can go all the way up towards the neck. So as a result, these patients have a very hard time bending over and touching their toes, kind of bending that lower part of the back. They have a hard time taking a deep breath in sometimes. They can't stand up straight against the back of a wall or the back of a door. And sometimes they can't even turn their neck, like when they're trying to drive and try and check their blind spot, they actually have to move their whole chest to do it effectively. These patients can get a lot of soreness and tenderness at the ropes that connect the bones to the bones, called the ligaments, or the ropes that connect the muscle to the bones, called the tendons. And this can also lead to dactylitis, where the whole finger or the whole toe becomes swollen, and you can see this on exam, like when they have that whole swollen finger or toe, it almost looks broken. These patients can also get what is called extra-articular disease, which means disease that is not in the joint, but is in other parts of the body, an autoimmune response. And so these patients can get inflammation in the water behind the whites of the eye. This also is a disease that can run in families, so they could have family members that are affected as well. So as far as who gets ankylosing spondylitis, well, it is a younger patient population. It's about 20s to 30s is when it will first start up, but it's still a very rare disease. So if you take the example of how many people do I need in a room for even one person to have this, I would need over 10,000 people in a room for one person to have this. It is more common in whites, and men tend to get more of the spine disease rather than the women who get more inflammation. It can run in families, as I talked about before, and actually it has a genetic marker, but the genetic marker is kind of something that only works one way, which means that if you take, for every 12 people on earth, maybe one person has this genetic marker, but you would need 100 of those people for even 5 or less than 5 to have ankylosing spondylitis. However, the opposite is not true, which means that a lot of patients who have ankylosing spondylitis will have this genetic marker. So even though that genetic marker is very common in the population, only a few of those will actually have ankylosing spondylitis. As far as the diagnosis of this disease, is just like everything else in rheumatology, where we take what the patient is saying, we match it up with what is happening on their bodies, and then we use labs or tests or x-rays to confirm that diagnosis. So in this case, we are looking for that morning stiffness, that inflammatory back pain, that fusion of the spine, sometimes the bottom, the middle, and all the way up. Then we are also looking for enthesitis, we are looking for dactylitis, and then we are looking for other issues like uveitis. And finally, we are also asking the patient, does this thing run in your family? Is this something that their brother has, or their grandfather had, or their uncle had, etc.? The labs and tests will show a lot of inflammation, and they will show this genetic marker most of the time. And sometimes the x-rays and scans, especially if the patient has had the disease for a while, it'll show erosions or eating away of the bone in the very low part of the spine, but then it can also show calcification of those ligaments. So meaning that the ropes that are connecting the bones to the bones become hard and they become bony, and it's a very specific type of bone spur that is made in these patients. It's called a syndesmophyte, and as a result, these patients, when you look at their x-rays, their spine becomes very straight, and because of these little connections, it looks very straight and also has like little lines in the middle. So it looks like a bamboo spine, or it's called a bamboo spine because it looks like the stalk of that plant. And then finally, in patients and with ankylosing spondylitis, how they are treated really depends on the severity of the disease. So for a lot of patients, NSAIDs can be used to help with the pain and the inflammation. Sometimes steroids can also help, but then we really quickly move on to steroid-sparing agents. So these are medications that will do the job of the steroids without the steroid side effects, and in this case, they will actually halt the disease or kind of stop the disease from going on to make permanent damage or deformities. And these medications do push down the immune system, so the immune system cannot become overactive the wrong way. And these patients, physical therapy is very, very important because now they are using joints that they shouldn't be using as much, so they can get more wear and tear of those joints. And as a result, they sometimes need surgery. They sometimes will need a knee replacement or a hip replacement, etc. As far as the long-term outlook for patients with ankylosing spondylitis, with treatment, they actually do very, very well. And again, treatment really depends on how severe this disease is. So is it the lower third of the spine? Is it halfway up their spine? Is it all the way up to the neck? And then is there any extra articular disease like uveitis, etc.? And then also, is there anything like osteoporosis or weakening of the bones? Because these patients, even though they have calcium put in the wrong places, but then they don't have calcium put in the right places in their bodies. So they can get more osteoporosis. These patients also get a lot of inflammation on the inside. So as you can imagine, the blood vessels get a little bit more sticky, and the smallest blood vessels go to the heart. So these patients do get more heart disease. These patients can sometimes also get more heart valve disease as well. And for some of my patients, I had some patients that the medications for this disease really came out in the 1990s. So I do have a few patients that would come in the 80s and the 70s, and there was nothing there that the doctor could give them for their disease. So they stopped coming to the doctor. And then in the 90s, when these newer medications came out, they kind of missed that window. So they did develop some permanent damage or some deformities, which now in clinic, I can give them medication to help them from getting the disease further, but I can't reverse what is already there, which brings me to the final point. In this disease, because it is affecting younger patients in their 20s and their 30s, it is important for the doctor when they talk to the families that they use non-medical words, because it's not just the patient that we are dealing with here. It's their parents, it's their family members, and also the other members that could be at increased risk of this disease. And now that there are amazing medications out for this disease, that yes, every medication has a risk, but in this case, the benefits far outweigh the side effects or the risks. As Galen himself said, the chief merit of language is clearness. Until next time.